Hi dear friends, a very good evening to all of you and welcome to this session, Clinical Thursday in DocTutorials. So friends, today's Ophthalmology Clinical Thursday is about cornea. So we'll be taking up few questions on cornea so that this topic will be strong. Because cornea is one topic which is there in every exam, be it NEETPG, INICT, be it FMGE. So corneal ulcers, keratoconus, these are some topics which are there in every exam. So let us start discussing about the cornea. All right friends, so welcome to the session. I am Dr. Shivani Jain, your ophthalmology mentor at DocTutorials, and we can be in touch at various platforms. I am freely available for any queries related to ophthalmology and your preparation. So without wasting time, let's now talk about the first question, the first clinical question that we have here. So friends, it's about a 55-year-old male who's developed pain and redness in right eye after a parotid tumor surgery on the same side. What can be the most likely diagnosis seeing the picture? So it's a picture question also, and it has some kind of integration with ENT, isn't it? It's a beautiful clinical question. So I would like that somebody would answer in the chat box. Yes, anyone? Would you like to answer? What kind of ulcer or what kind of problem will the patient have if he is suffering from pain and redness after a parotid tumor surgery? Anyone? Any answers? So guys, it's a very important expected question because it's a kind of clinical integrated question. So let me tell you, the answer to this question is neuroparalytic ulcer. Now let us talk about what happens when there's a parotid tumor surgery and what is the clinical problem here to the patient. If you can see, the patient is trying to close the eye. The left eye is normally closed. But what about right eye? Can you see the right eye is not able to close completely? Okay, so there is some problem with the lid. Now what exactly is the problem? Can I say this is a lag of thalamus? So another picture of lag of thalamus, guys. Please remember, lag of thalamus is because of problems in the orbicularis oculi muscle, isn't it? This is circular muscle which closes the eyelid, and this orbicularis oculi is supplied by seventh nerve. So any reason of facial nerve palsy can lead to lag of thalamus. Now guys, when this patient sleeps, what will happen? Can I say the cornea be exposed? So please see this picture, a beautiful picture of a exposure ulcer which we call as a neuroparalytic ulcer. So I'm sure that you are able to see that inferior part of the cornea has become so dry, isn't it? The reason behind this is that when the patient sleeps, the inferior part of the cornea will become exposed and it will lead to a dry eye, a severe dry eye, and it can further lead to a neuroparalytic ulcer. Alright friends, so please see, this patient is having a corneal ulcer only in the inferior part. So this is called as exposure ulcer. We can call it a exposure ulcer. It can also be called as a neuroparalytic ulcer. Okay, so both of them are same. Now, how to treat it, how to prevent it? So friends, first of all, we can patch the eye, isn't it? We can patch the eye. We can also put a lot of tear supplements so that the cornea doesn't become dry, isn't it? So tear supplements, patch the eye while the patient sleeps, and the third, a surgical procedure, we call it tarsorrhaphy. So it is another expected picture question. Please see that this part of the eyelid is being stitched, isn't it? We can call it a paramedian tarsorrhaphy. Okay, so this part of the lid is stitched so that while the patient sleeps, even if there is a lag of thalamus, the cornea will not get exposed. Okay, so please remember, why the correlation of parotid tumor surgery? I hope you know that whenever we do a parotid tumor surgery, sometimes facial nerve can be iatrogenically damaged, isn't it? So this damage can lead to problems like facial nerve palsy. Now guys, this question has been repeated earlier. They had given you just a picture question on to identify which picture is what. Okay friends, so this is lag of thalamus, inability to close the eye. This is ptosis, so please do not get confused. Whenever you are in doubt, just check the normal eye. If the normal eye is closed, the other eye is not closed, it is lag of thalamus. If the normal eye is open and the other eye is not able to open completely, this will be ptosis. Okay, I hope these two findings are clear. So there are so many picture questions related to this topic and a very beautiful integrated question with ENT. Now let's move on to the second question. So here we are talking about, okay, Dr. VKS Opto, if we are stitching that there is no problem, so I didn't say there is no problem, but definitely there would be a problem. But please see, this suturing is only in the lateral part, okay? We call it paramedian. Okay, we are not completely closing the eyelid. No, we are not completely closing it. We are just closing it in the paramedian part. Okay, so we can also, redefine it. If we are expecting a good recovery of the facial nerve palsy, we can refashion it. Okay, this is paramedian. See, exposure of the cornea is bad. Once cornea is gone, there's no coming back, isn't it? So better is to suture in few patients. It's not, we are not doing it in every patient, but somebody who's very old, who doesn't have anybody to support and who cannot come for the follow-up, so this can be one-time procedure. Okay beta, I hope this is clear. Now let's move on to the second question. Here we are talking about a regular contact lens user. Okay, so this is your first clue to your answer. A regular contact lens user presents with complaint of severe pain, redness, photophobia and blurring of vision for more than 2 weeks. Please remember, it's not responding to standard treatment. When you examined, there is a paracentral ring-shaped lesion with stromal infiltrates and overlying epithelial defects is observed in the affected eye. So what is the most likely diagnosis? So guys, any answers here? Any answers? So the answer to this question is Acanthamoeba ulcer or Acanthamoeba keratitis. Now guys, we have various clues. First and the most important clue is that there is a contact lens user. Now what do we have to suggest that this is a case of ulcer? So can I say again, we have PVR symptoms. What are PVR symptoms? Pain, decrease in vision and redness in the eye. So we have all the three things which are satisfying that our patient is having an ulcer. Now another very important statement is it is not responding to the standard treatment. So what do we mean by standard treatment? The meaning of standard treatment is that we are giving antibiotics to the patient. We are giving the standard treatment, but patient is not showing any response. How will it show response if this is a Acanthamoeba ulcer? Got the point, everyone? So this is a very important statement. An ulcer which is not responding to standard treatment, then you must think about other causes. Now let's quickly talk something about Acanthamoeba ulcer. I hope you know that Acanthamoeba is a free-lying protozoa which lives in the soil. We have a history of contact lens usage, or you can say misusage. Another history is bathing in dirty water. Okay, so these are two very classical histories you can have in Acanthamoeba ulcers. Now remember, this ulcer is the most painful ulcer. Okay, this is the very painful ulcer because it causes perineuritis. The meaning of the term perineuritis is that it leads to inflammation of the peripheral corneal nerves. So it leads to the inflammation of the nerve endings itself. That's why this ulcer is very painful. Okay, now it's difficult to diagnose because it mimics other ulcer. It may show you satellites, it may show you a ring-like fungal ulcer. Sometimes it behaves like a pseudodendritic ulcer. So you know, it mimics other ulcers. It sometimes behaves like herpes, it behaves like viral, fungal, etc. So it does not have its own characteristic feature. That's why it's difficult to diagnose. Okay, next important thing is that the treatment is also different. Treatment is by PHMB. What is PHMB? Polyhexamethylene biguanide. So remember this much about Acanthamoeba ulcer. This is another very important topic. Most painful ulcer, contact lenses, dirty water. Okay, difficult to diagnose, difficult to treat. Now, another question which has been there in NEETPG exam, which has been there many times in FMGE. So what is it? Let us talk about it. It's a simple picture question. I just look at this and I can tell you that this is what? This is herpetic ulcer. Yes, but we don't have something like this in the option. Let us try to solve the question. So there's a young man who comes with pain and photophobia. Okay, there's a young man, pain, photophobia, and there's a redness also. He describes that there is a viral fever since many days and he feels lethargic all the time. Now, when you stained with fluorescein dye, this pattern was seen. So obviously fluorescein dye has been used. I hope you know that fluorescein stains any epithelial defect or any ulcer green in color. Can you see? So this green color is what? This green color is actually the defect in the epithelium or the ulcer. Yes, everyone. So this is how fluorescein helps you in diagnosing. Now if you get this kind of morphology, this dendritic pattern, one ek ka do ka char, something like this is your dendritic pattern. And characteristically, if you see knobs, these knobs are suggestive of true dendrite. Okay, this is nothing but a true dendritic ulcer. Okay, dendritic pattern with knobs at the end. So this is the meaning of true dendrite. Let's come back to the question. Let's try to solve it. So it says option A, ulcer with knob head. So I have just told that this is the ulcer, this is a dendritic pattern and there are knobs at the end. This makes it a true dendritic ulcer. Okay. Now remember friends, very important statement, that in herpetic ulcers, the corneal sensations become less. It's a very important statement in your exams also. Herpes leads to decrease in sensations on the cornea. Okay, this can come to you again as a MCQ. Now what about rose Bengal dye? So yes, rose Bengal dye is another dye which is again positive for this ulcer. I'll show you a picture by which you can understand. So guys, can you see this pink thing? This pink is nothing but your rose Bengal dye, which has also stained the ulcer, but remember it is staining only the margins of the ulcer. So this can be another expected question. ठीक है बच्चे, like if you see fluorescein, it stains the base of the ulcer, but what about rose Bengal? So it is going to stain the margin of the ulcer. Another important expected question. I hope you know last year we had a question, which dye should be used first. So please remember, they can ask you another question on rose Bengal, that what exactly is it staining? So it is staining the margin of the ulcer, not the base of the ulcer. Alright, now let's come back to the question. So are you going to treat this ulcer with oral acyclovir? Not at all. So can I say this is the correct answer? Because it is an incorrect statement. What is the treatment of dendritic ulcer? We treat it by ointment acyclovir. So there is a role of ointment only, not oral. We don't require oral acyclovir. What about atropine? Yes, definitely atropine will be given. So atropine we will give, but not the oral. We will give ointment acyclovir. That is the treatment of choice. So guys, this is the correct answer. Alright, so keeping the same question in mind, so I had viral ulcer in my mind and I have just framed up one question, isn't it? They can ask you n number of questions from certain topics, right everyone? So history of viral fever, lethargy, it is suggesting that the patient is not having a very good immunity. That's why he can have a herpetic ulcer again. I hope this question is clear. Now what about this geographical ulcer? What is this geographical ulcer? So guys, if you happen to give steroids, suppose if you have given steroids in this case, what will happen? All these dendrites will join each other and it will lead to a very big ulcer, a huge ulcer, and this is going to be a geographical ulcer. I hope this is clear to everyone. So geographical ulcer will result when you give steroids in case of dendritic ulcer. So that's it. Alright guys, remember it's a very important question. Now something for you, a picture question. If this can be there in the question, like if they've given you this image, they can ask you various questions like which nerve is affected, which rule is being followed, and what is the picture. So first of all, this is a picture question. I hope you see. This is nothing but XZO. So guys, can you see the vesicles are affecting one side of the face, only the half of the face, and they do not cross the midline. Can you see? They are not crossing the midline. Second, if you notice that vesicles are present in all three cases at the tip of the nose. So vesicles are present at the tip of the nose. That means it is following the Hutchinson's rule. So what is Hutchinson's rule, friends? So Hutchinson's rule says that if the tip of the nose is having vesicles due to HZO, ocular involvement is likely to happen. Okay? After maybe 2 days, maybe 3 days, your cornea will get involved. Why? Next question, why? So it is because of the nasociliary nerve involvement. Nasociliary nerve is involved, which has the common nerve supply, which shares the common nerve supply, the tip of the nose and the cornea. Both of them are supplied by nasociliary nerve. Alright guys, so this can be another very, very important picture question, as Dr. Joseph has absolutely correctly mentioned. Very, very good. That's what I'm interested in. So next question, let's move on to the next question. So here we have a young male, 30 years old. He presents with difficulty in vision in the left eye. So vision is gone, right? And it's been for the last 10 days. Now, what is the real problem? So he is from a rural community and he gives you a history of trauma by vegetative material. So guys, most of the time, my question ends here. The moment I see that there's a history of trauma by vegetative material, what comes into my mind? The first thing which comes into my mind is that this is a case of fungal ulcer. Yes? Now, when I examined the patient, what did I see? I see there is a feathery margin, there is a hyphated thing, and there are satellite lesions also. So guys, what else do you want? You have everything which is suggesting that this is a case of fungal ulcer. Now, what do I have to find out? I just have to find out which is a fungus here. So what is a fungus here? Fusarium, isn't it? So it's a PYQ guys, but I am telling you fungal ulcer is a real important question. Every year we are getting one question from corneal ulcer, so this is one of them, right everyone? So let us quickly talk something about the fungal ulcers, right? Now friends, as I told you, many times fungal ulcers are diagnosed by their history. So there are two important histories. One, history of trauma by vegetative material. Second, very important, probably you might not be knowing that there may be a history of steroid abuse. Okay, many oldies, they have a habit of putting one drop something just before they sleep, and they say that the eye is cleaned. So they have a habit of putting a drop of steroid, okay, which is slightly irritant, and they feel happy about it, isn't it? So steroid abuse is also a very important expected question for your INI set and NEETPG, okay? FMG, they may not give you this thing. Bache, they are all worried about PDF, and you don't want to learn it right now. You all have everything. So that is from the app itself, bache. Okay. Hanji, so it's a live session. It will be there at the YouTube. PDF probably will not be there. Okay. So there is a history of steroid abuse. Okay. Now you have to give me 1 minute. You have to give me 1 minute, guys. I'm just coming back. Wait. I'm so sorry for that, Hanji. So I was telling you that two histories in fungal ulcers. The first one is history of trauma by vegetative material. The second one is history of steroid abuse, right? Now, usually it is seen in farmers, isn't it? Because they can have a trauma by vegetative material while they are working in the farms, isn't it? In the fields. So when they come to us, we see that there is a PVR. What is PVR? Painful decrease in vision with a red eye. Now, when I see the patient, I see there's a dry looking ulcer. The pain is less as compared to a patient of bacterial ulcer, but yes, definitely pain is there. Now, when I examine the patient, I'll see the ulcer does not have a sharp delineated edge. It has a feathery margin. Okay, the margins are not sharp, feathery margins. Now, many a times we also see a ring shape ulcer. So, this ring is a ring of Weasley. This is an immunological ring where antigen and antibody, they meet each other. Now, Next is that sometimes we see a hypopion. Hypopion can be there in any ulcer. So this hypopion is a very typical hypopion. This is a fixed hypopion and this is a unsterile hypopion. So why fixed, why unsterile? Remember, there's only one condition in ophthalmology where the patient will have a fixed and unsterile hypopion, and this is a case of fungal ulcer. Now what is the reason that the hypopion is fixed? The reason is that the fungal hyphae get mixed with the pus. So if fungal hyphae are mixing with the pus, it doesn't remain a liquid thing, isn't it? It doesn't remain a liquid thing. So it becomes a semi-solid thing. That's why when you ask the patient to move the head like this, the level of the hypopion remains stable. It doesn't move, like in case of bacterial ulcers or uveitis or anything. So please remember, a fixed hypopion, unsterile hypopion is seen only in fungal ulcer. The reason I have told you, the fungal hyphae gets mixed with the pus cells. Okay, this is the reason. Now, next important thing is that we can also have some satellite lesions. So what do you mean by satellites? Like, you know, planet, and satellites revolves around the planet. Okay, so what do you see in a fungal ulcer? You can see multiple ulcers nearby the main ulcer. So what is the reason? The fungal hyphae may go here, cause a small ulcer. Fungal hyphae may go here, cause a small ulcer. That is the reason. So multiple ulcers near the vicinity of the main mass. This is called as fungal corneal ulcer. Alright friends, so we have discussed so many points about it. Can anybody tell me what is the treatment for fungal ulcers? Anyone? So the treatment is we give 5% natamycin drops. Okay friends, and definitely remember that for any ulcer, because there is a pain, so you must give atropine like drugs, because cycloplegics are important to reduce the pain. Okay, please remember another important statement: with any corneal ulcer you must give atropine to relieve the ciliary muscle spasm, to release the pain. Am I clear with this? So we have discussed neuroparalytic ulcers, Acanthamoeba ulcers, viral ulcers, herpes zoster ophthalmicus and fungal ulcers. So very important questions. Okay, now let us move on to a very important pathology, not only for NEETPG INSET but it can be there in FMGE exams also. So guys, kindly try to solve the question. First read the question and tell me what are we talking about. हम किस बारे में बात कर रहे हैं, पहले आप बिना ऑप्शंस पढ़े मुझे सिर्फ डायग्नोसिस बता दो. व्हाट इज योर प्रोविजनल डायग्नोसिस? ओके फ्रेंड्स, लेट अस टॉक अबाउट इट. सो वी हैव अ यंग फीमेल. Many a times age and sex also tells us so many things about the case, isn't it? Now let's again go back to the question. So a young female comes to you with a history of using glasses since early childhood. Okay, she may have a myopia, maybe an astigmatism. Now she is young now, so she is now telling us that she used contact lenses also since many years. Okay, contact lens BM. Now when you examine, you saw that vision is not so good. Vision is not so good. And there's a refractive error, something like this, which is twisted, which is kind of complicated. I just see this refractive error. I said it is a complicated kind of thing. Okay. Now, as I am not comfortable reading her refractive error, she is also not comfortable with her glasses and contact lens also. She is not comfortable with anything. Okay. Now when she came to me, I noticed that cornea is thin and cornea is also more curved than normal. So guys, what is the diagnosis? First of all, anybody, what is the differential diagnosis? Jaldi bata do, what is the diagnosis? What is this condition? Classical presentation of a patient of what? Uncomfortable with the glasses, not even comfortable with the contact lenses. So what is it? Can I say this is a case of keratoconus, guys? Yes or no? Yes or no? It's a classical presentation of keratoconus. Young patient, not comfortable with glasses, difficult type of refractive error, a high cylindrical power, and the vision is also not improving with glasses or by contact lens. And when you notice cornea is thin and more curved than the normal. So we'll come back to the options. Let's try to find out what is keratoconus. Okay, please learn keratoconus with me now. So friends, keratoconus, first of all, it's an idiopathic condition. it is a progressive condition also, and it is ectatic condition also. What is ectasia? Ectasia is protrusion. Okay, so it's idiopathic. I don't know what is the cause. It's progressive, and it's ectasia of cornea. So can you see, while normal cornea is like this, in keratoconus there is a progressive conical shape of the cornea. Okay, please see this picture also. There is a progressive conical shape of the cornea like that, isn't it? So please remember, if cornea is progressively becoming conical, what will happen to the refractive error? Refractive error can never be stable, isn't it? That's why these patients are not comfortable, because their glass number, their contact lens number is not stable. Okay, now what do you expect will happen to the refractive error? What type of refractive error do you expect if the cornea is changing curvature? So I expect an astigmatism, isn't it? So that is what we get in our prescription. This is a case of astigmatism. Yes, everyone, vision is not improved. So let us now talk about it more. So friends, there are various signs when such a patient comes to you, a young patient, not comfortable with the glasses or contact lenses, vision not improved, and there is the astigmatism. Think about keratoconus. Now, at the age of 18 to 20 years, when we expect the number should get stable, these are the patients, they are coming to us with such a problem. The number is not getting stable. Alright, so that is how you have to identify that we are talking about keratoconus. Now when I examine the patient, I will first like to do the keratometry. What is keratometry? Keratometry से हम क्या check करते हैं? We check the curvature of the cornea. So obviously the curvature of the cornea will be more. Keratometry पे ज़्यादा होएगा curvature of the cornea, है ना? Now there are so many signs, but the most important signs for you as a MCQ, as a picture question is this. So what is Munson sign? I hope you all can see that there is a beautiful notch of the lower lid when the patient looks down. So why there is a notch? The notch is because of the pressure by the cornea. Because the cornea is getting bulky, it's getting protruded. So when it moves down, it creates a notch on the lower lids. It's a beautiful sign. But remember, this is not an early sign, this is a late sign, isn't it? Early, what do you see? So early we see so many signs like scissoring reflex, oil droplet reflex, we have Fleischer's ring, as in iron accumulation on the cornea. We may have stress lines on the cornea, which is called as Vogt striae. Yes, everyone? So there are so many signs which you must remember for keratoconus. Now, how to diagnose this patient? Another expected question in FMGE exam. Please see, this has been there in NEETPG exam. So the diagnosis is by pentacam. INICT NEETPG, guys, they can give you picture question. What is this picture? If you can see this, there are 4 color coded maps. Okay, this is for right eye only, OD right eye. This is for one eye. 4 color coded maps. So every map tell you something as a beautiful thing in the cornea. It's telling you some important information about the cornea. So kindly see. So one of the maps tells you thickness of the cornea at multiple points. One of the map is telling you curvature of the cornea at multiple points, isn't it? So आगे पीछे ऊपर नीचे, it's telling you everything. So everything about the cornea is what? Pentacam, which tells you about the topography of the cornea. Alright friends, remember, pentacam is the best for diagnosing any corneal problem like related to curvature of the cornea or thinning of the cornea. ठीक है बच्चे? So these are about the signs. You will see the cornea has become thinned. Now guys, for INICT and NEETPG, they can give you another question like this, that red in the center. So red means hot colors, danger. Red isn't red signify danger? So danger means abnormal. That means it tells you that there's a thinning in the central part of the cornea. So this is likely to be keratoconic cornea. Okay friends, green means good. Green means normal. Green is normal signal. So green is normal pentacam and red is abnormal pentacam. So you can remember like that. It's an easy topic. Now friends, if we talk about the treatment, so how to treat? So first is to treat by C3R. A PYQ for NEET exam. So C3R is what? Corneal collagen cross linkage by riboflavin. So it is said that if you put vitamin B2 drops as in riboflavin, and if you show the patient ultraviolet light for half an hour, what will happen? It will produce new corneal stromal bonds. So collagen synthesis will increase. Now if collagen synthesis will increase, the ectatic cornea will now become strengthened. It will become stronger. Yes or no? So cornea will get more strength. Now when cornea gets more strength, the further progression of the conus, the further progression is stopped. Understood, friends? So first of all, remember C3R is the treatment of choice for stopping the progression. So you stop the progression by making the cornea strengthen. So is it the end? No, it's not the end, because you want to make the cornea normal. You want to make the curvature come back to normal. So what to do? So friends, for this we have two options. To make the corneal curvature back to normal, the first option for us is putting contact lenses. These are rigid, permeable, gas permeable contact lens. So it is said that if you put rigid gas permeable contact lens for a long period of time, the corneal curvature will come back to normal. Okay, so this is the first option. You can put rigid gas permeable contact lens. Okay, bete? Now, another option is that you can put Intacs by doing a surgery. So it is by using femtolasers. You have femtolasers in ophthalmology. So you press a button of femtolaser and it will create passage so that we implant 2 PMMA semicircular rings. So this is one semicircular ring and this is another semicircular ring. So this we are putting inside the stroma of the cornea. So it is said that if you put Intacs 2 PMMA semicircular rings inside the stroma of the cornea, it will have the flattening effect. That's what we want. My cornea is becoming more curved. Yes? So how will I flatten it? By putting Intacs in the corneal stroma. Alright friends, so again going back to the treatment. First do C3R, stop the progression. Now cornea is this, it's not further progressing. Now two options by which you can make the curvature back to normal. First is by putting contact lens for a longer period of time. Second is by doing a simple surgery. This is called as Intacs. You put 2 PMMA semicircular rings inside the stroma of the cornea and hence the cornea will become stable in curvature. Alright friends, so this is all about cornea which I would like to share with you today. I hope you are reading well, you're preparing well for your INI set, for your upcoming FMGE exam and your next 2024 or NEETPG 2024. So wish you best of luck from everybody at DocTutorials, from me, Dr. Shivani. So you can be in touch, you can contact me at any platform. I'm very readily available at DocTutorials, and any query which is related to the subject, guys, you can ask me. So we shall meet again on one of those Thursdays. We'll take up one more topic. If you have any suggestions that you want to read something from me, please let me know. In the next Clinical Thursday program, I'll take up that topic. Okay, so best of luck for your preparation. I hope you learned something and you would be able to solve all the questions related to the cornea. Okay guys, chalo. So that's it. Any questions, anything which you wish to ask? Acha, I think I forgot to get back to the question. I'm so sorry guys, I forgot to tell you the answers. So can I ask you the question? How are we going to answer this? So she has irregular astigmatism due to keratoconus. She can undergo LASIK as she is not comfortable with her glasses. It's an idiopathic progressive condition. Best is to get C3R followed by Intact. So any answers from you now? Now that we have read the topic, can you answer? It's a very important topic guys. Can you answer me now? Can she undergo LASIK? Remember, LASIK, we have read LASIK. So can you do LASIK in keratoconus? LASIK is a big time contraindication guys, LASIK. So if the patient is not comfortable with the glasses, that does not mean we can do LASIK in every patient, okay? We have just discussed that this is a idiopathic progressive condition. Best is to do this. And if you can see the prescription, this is an irregular kind of astigmatism due to keratoconus. So all three statements are correct. I hope you know that LASIK is absolutely a contraindication in patients of keratoconus. The reason, there are two reasons. First, the power is not stable. What power are you targeting? Second reason why we can't do the LASIK here is that cornea is already thin. You can't do LASIK in a thin cornea. All right, friends? Okay, so this is the case. I hope you learned something and you enjoyed today's session. Thank you everyone. Bye bye. God bless you.